I wanted to say that CommonSpirit Health over the last years has focused in the area of LGBTQ T plus care and at a variety of levels, including at the system level with policy, procedure, signage, proper addressing patients with proper pronouns, and clinically. And I want to just share one slide that sort of encapsulates that work. And it's within the context that we're having this conversation this morning about PrEP and PEP care. So John, if you can share that. It just simply says this, that there is an LGBTQ plus clearinghouse and steering committee at the system level. And beneath that have been several work groups. One is that the health system has worked in what is called the Healthcare Equity Index for 2003 work group, where we have achieved high status with that group. There's a policy work group, the transgender policy, and that has lots to do with how we present to patients and how patients present to us. And the group that I want to highlight that is really speaking today is the Clinical Advisory Committee or Clinical Advisory Group that lives under the Clearinghouse and Steering Committee and is part of clinical standards led by Dr. Ankita Sagar as well. We have a group of about 10 people who are our clinical advisors and work around policy and actual clinical training. And you can see beneath that a clinical operations team and a clinical training task force where we are working to develop training modules for two tracks. One is for primary care physicians who we believe should have a general knowledge of LGBTQ plus care, which includes things such as PEP and PrEP. So this is part of that work. And then a sort of a specialty track for people who are interested in more advanced skills to provide comprehensive care to LGBTQ plus patients. So with that, we are very happy to be here. This is Pride Month, and so all of that fits together. We have one survey question to start, and then I'm going to turn over to Dr. McGinn for introductions, and then to our speakers. So with that, John, if you we're going to ask you two questions. If you could just quickly vote. Here they are. What is the frequency with you / your clinical team provides screening for and counseling on the prevention of sexually transmitted infections? Single choice, never, rarely, sometimes, often, and very often. And what is the frequency with which you or your clinical team provide counseling on pre-exposure prophylaxis, PrEP, or HIV prevention? Single choice. So if people can vote, with the exception of the panelists, we'll see the results and then we'll turn it over to Tom. Here we go. So the first question, what you can see is is folks 41%, sometimes 24% often, and 29% very often. So I think that's an indication of where we are, and that looks fairly healthy. Let's see, and then there's one more, John.
Gary, if you scroll down, you can
sorry.
No problem.
Here we go. So with what frequency do you or your clinical team provide counseling for PrEP or HIV for prevention? And here you can see that at least over 50% of people rarely or never, 18% sometimes, 24% often, 6% very often. So there's opportunity here for us, and that is exactly what our conversation about this is this morning. So Dr. McGinn, welcome. Thank you for joining us, and we'll turn it over to you.
Great, thanks, Gary, and thanks everybody for all the amazing work in this space. It's just one of those things that I know we're constantly striving to do better, and we are so happy to see this team come together and really excel in this space. So let me quickly introduce folks before we run out of time. Just introducing everybody. We have a lot of speakers today. We have Dr. Stannano. Am I saying that? Centeno. Am I saying that right, Marcia?
It's Alcalumbre Centeno.
Okay, the whole thing. Okay, Alcalumbre Centeno. Okay, I tried. I did the best I could. Board certified internist, infectious disease trained, fellowship HIV care since 1993. After completing her fellowship, she worked in Ryan White something I've done in my past HIV program in UC Irvine for 11 years, and has been the medical director of the CARE program at St. Mary's Medical Center since 2004. We have Benjamin Lomelli, who is a biomedical prevention services coordinator at CARE and works diligently to bridge the gap between the communities and healthcare by fostering a stigma-free environment where patients feel empowered to discuss their sexual health. Paul Lovely, my favorite last name, is the director of CARE Center at St. Mary Medical Center in Long Beach, California. Since 1999, Paul has dedicated himself to working with patients living with HIV in various roles at St. Mary Care. And finally, we have Christine Gutierrez, is a nurse practitioner who has been a PrEP and PEP lead practitioner from 2016 to present at the Dignity Healthcare Clinic at St. Mary's Medical Center in Long Beach, California. Did I get all that right? All right. Well, thank you all for joining us in this extremely important discussion, particularly during Pride Month. So I'm really happy we're doing this. So who's up first?
I think Paul is, and I should mention that St. Mary's Hospital in Long Beach is a Dignity Health CommonSpirit hospital.
Great.
Okay,
Paul,
I think
all
you're
right.
on. Oh, we got Christine here. Great.
Great. The whole team's here. All right. So, yeah, we'll go ahead and get started. First, let me just say I'm really grateful to be here and to be part of this group. You know, going down this path together, I think it's great, and I think it validates a lot of our work that we have been doing, and it really makes me excited to be able to continue to do this work. This talk this morning is entitled HIV Prevention, Prescribing, Pre-Exposure Prophylaxis, or PrEP. Next slide. And quickly, the objectives to review the role of PrEP in the National Ending the HIV Epidemic, or EHE, strategy, to learn about available PrEP efficacy and safety, to identify those who will benefit from PrEP, to learn about taking a sexual history, understand PrEP monitoring guidelines, and to learn about PrEP funding and resources. And so, disclosures are here. Dr. A with paid consultants Vive, and then some of these materials we just want to clarify that some of the materials here are were developed by the CDC, and there are also many of these resources are available on the CDC website. Next slide. And then just briefly to tell you about the Care Center. The Care Center at St. Mary Medical Center was founded really at the beginning of the AIDS crisis in 1986. And we've grown over the years to become the largest provider of HIV services in the South Los Angeles County. We serve over 2,000 clients. About 1,600 of those are clients living with HIV, and then another 400 to 500 are clients who see us who see us for PrEP, PEP, or other sexual health services. We have a medical clinic, which gives HIV specialty care. We're an LA County rapid antiretroviral site, so people who come to us, we can get them started on HIV meds within a day or two. We also, of course, we do PrEP, PEP, STD screening and treatment, and we're also at LA County PrEP Center of Excellence, which we're proud of. We have a dental clinic. We have a multitude of support services, including behavioral health counseling, medical care coordination, home-based case management, benefits counseling, AIDS drug assistance program, and in California, we also have the PrEP version of that, which is the PrEP assistance program, which helps for costs for PrEP. We also have a food bank, nutritional counseling, and housing assistance. So a lot of stuff. Next slide. And so, yeah, just to kind of put this into context of kind of the larger kind of national strategy, this ending the HIV epidemic in the US, or EHE strategy, has been around for a few years. And really the overarching goal of the EHE initiative in the United States is, first of all, to reduce new HIV infections by 75% in 2025, which is going to be here any minute, and then by 90% in 2030. And to do this, there are four key strategies, and PrEP figures very prominently in these. But first, to diagnose all people with HIV as early as possible. Second, to treat people with antiretroviral therapy and to reach sustained viral suppression. So not only to get people undetectable, but keep them retained in care so they stay undetectable. Of course, if their virus is fully suppressed, they cannot go on and infect others. And then prevent new transmissions. That's where PrEP comes in, and some other tools we have in our prevention toolbox. But we really have these days a really potent toolbox of prevention tools to prevent HIV infections. And then fourth, to respond quickly to any HIV outbreaks and get prevention treatment services to people who need them. So that's that. Next slide. And then just to give you an idea where, and then there are some other goals as well with the EHE strategy. And this is just showing HIV infections in the United States, annual HIV infections. And you'll see like in 2015, we had 37,800 new infections, and that had plateaued. Between about 2010 and 2015, we were hanging out around the same place, but we've started to see the new infections decrease. In 2019, we were down 8% from 2015, and but you'll see though here too that we're quite a long way from the goal in 2030, which is to have only 3,000 new infections. Next slide. And just to give you an idea of how we're doing nationally with PrEP, uptake and access and uptake. The goal with the strategy is to have 50% of eligible meaning people who are at high risk for HIV on taking PrEP. And overall, we're halfway there. About 25% of high-risk folks are on PrEP currently. We've really ramped up in the past few years, but again, have a long way to go. And we also have a long way to go with certain, certain populations. And we see these inequities in all kinds of areas in healthcare, and certainly with this as well. Black clients, Black folks make up almost close to half of people living with HIV, but only 9% who are at high risk are on PrEP. And then with Hispanic, Latino, or Latinx folks, 16% nationally, though I will say at our clinic, over 50% of our patients are Latinx. So we're proud of that, but we don't do as great with our Black community members. And then of course, white people at risk for HIV have access to PrEP much more easily than other groups generally. Next slide. And then this is just, to look at this in another way, looking at age, and actually the PrEP to need ratio, meaning the greatest unmet need for PrEP of all age groups, that teenagers and young adults had the highest unmet need for PrEP. So that's people who are ages 13 to 24. They have the highest PrEP to need ratio, but we still haven't done a very good job of reaching the younger patients, and that could be for a lot of reasons. So with that as the backdrop, I think I will. Next slide. Yes, I'll turn it over to Dr. Al-Kaloumreh.
Hi, good morning, everybody. And again, thank you for having us do this presentation. Go ahead to the next slide. So as Paul was alluding to, PrEP is one of the tools for prevention of HIV infection, and it's the use of antiretroviral medication. So that people who do not have HIV can protect themselves from getting HIV. And per national guidelines, it is recommended for those who are at risk, adults or adolescents. Basically, there's two forms of PrEP that's available. There's the oral form and an injectable form. So what first came out was the oral form, and So in the kind of teal box, the first medication that was out was emtricitabine and tenofovir disoproxil fumarate, which is now available both as the brand name of Truvada and a generic equivalent. And this is one pill combined with these two medications once a day, which has been found to be very effective in preventing transmission of HIV. And this medication is available to any adult or adolescent who is at risk. Then it was chemically changed a bit so that it's still the emtricitabine, but combined now with tenofovir alafenamide, or otherwise known as TAF. And this is available only by brand name, which you see there, Descovy. And it's still one pill once a day. And this is was approved for men or for transgender women who were not at risk for getting HIV through receptive vaginal sex. And that's because the studies were really done in just the men and transgender population. And then finally, injectable PrEP came out, and that is cabotegravir, and that is an injection. People do need to come into the clinic to get the injection, and they get a loading dose with one injection, then one month later, and then after that, it's every 2 months. So once they're on a maintenance things, it's basically 6 times a year that they come in and they get an injection. Okay, next slide, please. So there have been multiple studies through the years that have shown that if PrEP is taken as prescribed correctly, that it can be highly effective in preventing transmission. In initial studies, the success rate was lower, and what was found out was that people really weren't taking it every day. And so as more was learned and people started taking it daily, studies show that very high levels of adherence correlate with high levels of effectiveness. And we can see with sexual transmission, it can prevent sexual transmission about 99%. For injection drug users, this estimate's based on just the tenofovir Truvada studies, and that is shown to be at least 74% effective. Okay, next slide. So when you're looking at not at giving somebody a medication to prevent transmission, we want to know that it's effective. We also want to know if they'll take it based on side effects and safety. So generally, it's very well tolerated when they first start it. Some patients may report some headache or nausea or some abdominal symptoms with the oral medications. That usually resolves pretty quickly. And then, of course, with the injectable, they don't have those GI symptoms because it's injected and not taken orally. When we're looking at the oral forms, again, one issue that we do look at is renal safety. We've known for a long time in HIV in using these medications for HIV that we can see small increases in creatinine or decrease in creatinine clearance with tenofovir, and so we do monitor renal function with this medication. One of the advantages when FTAF was released was that it had much less renal toxicity than the tenofovir TDF form. And so we can see less kidney issues with that, with the new form, the TAF, in HIV and in HIV prevention. And then with the cabotegravir injectables, that is not an issue. The other side effect and safety issue for the tenofovir TDF is bone safety. We can see decrease in bone mineral density in small amounts. Generally in younger healthy patients, that has not been a big issue or associated with fractures. But again, the newer formulation does correct that issue. And then again, also with cabotegravir, there is not a bone issue. One of the most common side effects with the injectable cabotegravir is an injection site reaction. So this is, they're actually given they're given one injection. Usually it's gluteal, and it can cause pain and tenderness and some local skin swelling. People usually do get used to it, and it generally doesn't cause people to need to go off the medication. And then finally, with the FTAF, there are reports of weight gain and increase in lipids. And so you're getting the benefit of the kidney and bone safety, but you may be seeing the weight gain and increase in lipids. So that is something to also consider in patients who, when you're deciding between the FTAF and the TDF. Okay, next slide. And so this is kind of a summary of what we were just talking about, just remembering that there are 2 oral options, and both very, very similar medications, but they both are 1 tablet once a day, just that the TAF is not approved for women or transgender men who could still be having receptive vaginal sex. And then the renal safety, or if they have a lot of other comorbidities where you're worried about kidneys, if they have hypertension and diabetes and they're on a lot of other medications, then you may favor using the TAF FTC product. For bone safety, same thing, but for the weight gain and lipids, if that's your higher concern, then favors using the TDF formulation. And then I do want to point out that the TDF FTC is the only one that's available as a generic form. And so costs can definitely be affected by being able to use the generic form. And then in oral versus injectable PrEP, the studies that were for approval of the cabotegravir did show a superiority or lower incidence of HIV infection with cabotegravir over the oral options. Well, it was those studies did compare it to TDF FTC, not to the TAF. But with the that was generally led by adherence. So they're coming in and getting their injection, whereas patients on the oral option may not be taking it. And so because of that, the injectable was found to be superior. And again, as I said, that is 2 monthly shots and then every 2 months. And so, and again, this is approved for all, but you really do need to take the administration considerations of bringing the patient into clinic and having the infrastructure to do these injections. And okay, that's it. Next slide, please. One other off-label way of prescribing PrEP I do want to mention, and this is called the 211 oral PrEP. And so this is off-label, but it is for people who say they really don't want or can't take an oral medication every single day, or if they're having sex encounters less frequently, and so they want just something more on the spot. It does take a little preparation on the patient's part. They have to anticipate that they are going to be sexually active and take 2 pills 2 to 24 hours before sex, 1 pill then 24 hours after, and 1 pill 48 hours. So although this is not in the FDA approval, this is also used. Okay, next slide. And I just also want to mention, if your clinics have transgender people, PrEP can be safely used with their hormonal therapy. All 3 regimens are approved for transgender women, and then the TDF, FTC, and cabotegravir are approved for transgender men. And okay, and next slide. And then I just really also want to emphasize to a general audience, to this audience, and anybody who is not an HIV specialist like our clinic is that you still can definitely prescribe PrEP. PrEP can be prescribed by any licensed physician or by any licensed practitioner. It can easily be integrated into a primary care practice. We're used to doing preventive screening. We're used to giving medications to prevent things. I think statins are a great example, that we're trying to prevent cardiovascular disease. We're trying to prevent stroke. Contraceptives are, to prevent pregnancy. So it's, so for physicians they can be very overwhelmed with HIV medications, but with PrEP, it's, it's one of the oral medications, or if you want to incorporate the injection schedules into your office setting, it's definitely something that can be incorporated into a primary care practice. And it's also just such a strong way of getting this out to people who may not have access to these HIV specialty clinics or programs, or, to the populations who may not seek those type of specialty clinics. So this is one area where, as far as ending the epidemic, we can really expand into primary care setting. Okay, next. Okay, so now I'm going to turn this over to Christine Gutierrez, and she's going to talk about risk assessment. Christine has been working at our clinic for many years, and she is the one who has been running our PrEP and STI program. And so, Christine.
Hi there. First of all, I do want to say that the important thing is don't project your own experiences, your own sexual experiences, or your own expectations on when doing a sexual history. Okay, and I'm going to give you 3 examples. 45-year-old patient, married, teacher, secondary school teacher, comes in for STI testing. And in the course of informing him about PrEP, he then discloses that him and his wife are members of a swingers club, and he's very interested in PrEP now that he is aware of it. And he also wants to bring his wife in order to get on PrEP. Okay. Another example is a 73-year-old patient who has been on PrEP for 8 or 9 years now, married, grandfather. His wife knows nothing of his gay alliances. He chuckled to me one time because he says, my doctor never tests me for STIs, okay, because his doctor has no idea of his sexual activity. And then the third example, keep in mind that PrEP originally was only recommended for people 18 and above. I received a call from a pediatrician that her 15-year-old patient had told her that he is sexually active, and he has had 10 sexual male partners in the last 6 months. And I think you can recognize that in each of these cases, PrEP is definitely something that will assist us in bringing our HIV levels lower. Okay. One more thing to keep in mind, though, is that there is no sexual requirement, no sexual activity requirement in getting PrEP. And the reason for that is that patients may not disclose to you exactly what their sexual activity is the very first time that you see them. So it's best not, there's no requirement. If you explain what PrEP is about and they tell you that it's something that interests them, they'd like to go on it, prescribe it, okay? It may be months before they do tell you honestly exactly what their sexual activity is. Okay, so the thing to do is, of course, tell patients that you ask all patients about their sexual activity. You're not just choosing them, okay? You ask all patients about their activity, and that everything that they tell you will be confidential. And these are attempts to gain the patient's confidence. Okay, next slide. The first thing that I usually ask them is, are you sexually active? Okay, are you sexually active? And then I ask, do you have sex with men, women, or both? Okay. I don't ask them a question as if there's a right answer. I don't ask, for instance, do you take your pills every day? Okay, because the answer is going to be yes, of course. I ask, do you use condoms sometimes, always, or never? Okay, then you get an idea of how often is this patient using condoms. The next question I ask is, do you have vaginal sex, oral sex, or anal sex? This helps you evaluate their risk. Okay, It also puts you in a position where you can better educate them on ways that they can keep themselves safe. So if they do have anal sex and they're male, ask if they are the receptive partner or the bottom in the vernacular, or are you the insertive partner or the top? You'll find that some patients say that they're only the top due to it's their preferred method of sexual enjoyment. But some patients also tell you they're only a top because they want to lower their risk of HIV. Okay, so you can also advise patients about the higher risk with receptive anal sex over insertive anal sex, because some patients will modify their behavior if they do find out about that particular information. This information also gives you ideas on how often you should be testing your patients for STIs. Let's see. Okay, the next question is, do any of your partners have HIV? The way I usually word that, some people do know that one or two of their partners definitely have HIV. Okay, some people, they don't know if their patients have HIV. Some patients, they know that their partners are all on PrEP and they do not have HIV. But so what I usually ask is, are you always sure that your partner's HIV status? Okay, some cases yes, some cases no. I'm not really sure of what the HIV status of my partners is. Okay. Then we get into injection drug behavior. Do you use injectable drugs? Do you use recreational drugs that you inject? And if they do you ever share needles? And that also opens up a lot of conversation. Next slide. Okay, so when you do go through this, essentially, if someone has had an STI in the last 6 months, or is having unprotected sex, they're candidates, they're high-risk candidates, they're high candidates for PrEP. Now, of course, on this chart, it says prescribe PrEP, but if you don't get their buy-in, they're not going to use it. But in my own personal experience, as I'm talking to the patient, depending on what their activities are and how high their risk are, initially they might be a little unsure as to whether they should, but it is a good opportunity at that point to bring up what their behaviors are and what their risk is. And the patient might decide that, you know, PrEP really is a good thing for me. So yeah, the sexual history all goes into giving you the tools as to how much you should emphasize going on PrEP. So some of these say you don't have to give it to them. The other says prescribe. But in my world, it's how highly should I be recommending that they do go on PrEP. Okay, next slide. Another thing, I do have a couple of patients whose partners use injection drugs. And therefore they want to be on PrEP because they don't know what's going on with their partner. So whether they use injection drugs, have used them in the last 6 months, and definitely if they're sharing needles, PrEP is definitely something that's good for them. Or if their partner is using is using injection drugs. And again, this gets into the category, do you know the HIV status of your partner? No. Okay, so if someone's partner is using drugs or injectable drugs, then PrEP is definitely a good opportunity. So next slide. There you go.
Okay, so thank you so much, Christine. And hopefully that that now you've assessed your patient as she was describing those different scenarios and decide that you do want to prescribe PrEP. And go ahead to the next slide. The first thing that you really want to do once you've decided that you do want to use PrEP is that you do want to do baseline lab testing. So an HIV test is absolutely required to confirm that they're negative. If you get a positive HIV test at this point, then obviously you're going to refer them for a full HIV treatment or start them on HIV treatment if you're a site that is doing so. Once you've confirmed that they're HIV, so you want to confirm that they're HIV negative. Then you also want to assess their kidney function because that's going to help you in your assessment of which medication you may you may use. So if you're using TDF, their creatinine clearance has to be over 60, and for TAF, the creatinine clearance has to be above 30, and for cabotegravir, there's not a creatinine clearance requirement. So we always get a baseline renal function. We always get a baseline HIV test. The other tests that are recommended to get at baseline is hepatitis B screening. And the reason is because FTAF and FTDF do have activity against hepatitis B. And if they are hepatitis B positive, then there's issues about if safety with these medications, especially if you are going to stop a medication. So we always want to know what their hepatitis B status is. And then also as an aside, if they are hepatitis B negative, you want to see about vaccination if they are not already protected. We do baseline lipid profile because if a patient's going to go on FTAF, we want to be able to monitor their triglycerides and cholesterol. And then STI testing is also recommended for all sexually active adults at this stage. Next slide. So then once they're HIV negative and you've decided, say you've given them one of the oral options, then you're going to have the patient come back every 3 months. We see them, so quarterly we get a repeat HIV testing because we want to make sure that that we are continuing to follow that they remain HIV negative. If their HIV test is negative, then we would prescribe another 90 days of PrEP. At this time, it's you can talk with them again about their sexual activity, if they're at risk for other STIs, and give them additional support. One thing we haven't mentioned yet is that, by being on PrEP, we also always counsel people that does not protect them against other STIs, such as gonorrhea, syphilis, chlamydia. And so we still do counsel about condom use, and we do frequent testing. Then every 6 months, we monitor their creatinine clearance if they are at risk, and screen for the STIs. And then at least once a year, creatinine clearance for everyone, and triglycerides and cholesterol monitoring. Okay, next slide. For injectable PrEP, it's a little bit different. We also, because at the beginning we're doing the injection after 1 month, so we would test for HIV at that point, and then they're there every 2 months. So we again are getting an HIV test every 2 months for PrEP, injectable PrEP, and we're getting both the antigen antibody test and a viral PCR test. And then once we know they're negative, we do administer the cabotegravir. And similarly, we do all the STI screening. Okay, next slide. If someone does come back HIV positive, we want to take additional steps to confirm that. We assess if they really were taking their PrEP, because if they hadn't been, then maybe that is the reason, and then they are at higher risk for it being a true breakthrough. We do repeat the testing, and if someone is found to have HIV, then we would want to link them right away to HIV care and treatment. If you feel like they're at a very high risk for having actually converted to HIV, then you can manage their PrEP use while you're waiting for that confirmation test. You can increase them up to a full HIV regimen, which basically would be 3-drug regimen instead of only 2. So adding a third medication in to give them a full regimen, or you could stop the PrEP altogether until you get the HIV test back. If it was an injectable PrEP, then you would not give the injection until you've proven that that if they're positive or negative. And if you have uncertainty about this or questions, then you could also consult either the PrEP line or a HIV specialist. Okay, next slide. So now I just want to turn it over to our part on accessing PrEP and available resources. Ben Lomelli has been instrumental in our clinic as being our PrEP coordinator. And so, Ben, I will send it over to you.
Yes, absolutely. Thank you, Dr. A. Hi, everyone. Good morning. My name is Ben. I'm the PrEP navigator here at Care Clinic. And really my role as the PrEP navigator is to address any anxiety or worry over the cost of the medication or even medical visits and lab work that is part of PrEP care. So I'm going to talk very briefly about some of the programs that exist to kind of eliminate some of those barriers in accessing PrEP. Next slide, please. So fortunately, there does exist many programs available to patients. For instance, state Medicaid programs as well as health insurance plans under the Affordable Care Act actually cover most of PrEP medication and clinic visits. So if a patient is eligible to enroll into a state Medicaid program, that's highly recommended because it is covered under those plans. We also have pharmaceutical companies that offer patient assistance programs. For instance, Dr. A has talked about both options, oral PrEP and injectable PrEP. Under the oral PrEP option, Gilead Sciences offer their patient assistance program to cover the cost of Truvada and Descovy. And Vive Connect offers a patient assistance program to cover the cost of the injectable. So really what I do in my role on a regular basis is enroll patients into these programs by submitting an application to the appropriate vendor, also assisting patients and connecting them with state Medicaid programs. And depending on where you're located, your state may offer a patient assistance program. So here in California, we have the PrEP assistance program that's managed by the California Department of Public Health, which is a really great program for patients who are entirely uninsured or underinsured. Depending on their annual income, they may be eligible for this program, which actually covers the cost of their clinic visits, lab work, and in some cases, the medication itself. If the patient has issues around confidentiality, PrEP app will cover the costs of all medication, clinic visit, and lab work as well. The CDC has a plethora of resources that you can actually access and help locate if your state has any assistance programs available to you, which is really helpful in terms of eliminating any of the costs and access to PrEP. So next slide, please. And I believe the CDC also offers resources to prescribe PrEP. So information about what Dr. A was talking about, clinical practice, sort of general information about what HIV is and how PrEP works, the difference between oral PrEP and injectable PrEP. And so this information is available on CDC website. Next slide, please. And additional prescribing information and advice, which can be accessed using this phone number here. Next slide, please. And a really cool, handy checklist is available for providers that can help support them in prescribing and talking about PrEP to their patients. Next slide, please. And I'll hand it over to Dr. A for the conclusion.
Okay, so we've covered a lot of information. Just want to reiterate that PrEP is such an essential pillar in ending the HIV epidemic and in preventing the transmission of HIV. We've discussed the two oral forms of PrEP, the TDF-FTC and TAF-FTC. Both are one tablet once a day, and then the one injectable form of cabotegravir. When taken as prescribed, PrEP can be 99% effective in reducing the risk of HIV transmission through sex and 74% through IV drug use. We've reviewed how important it is to screen people at risk with a sexual history that's non-judgmental, discuss PrEP with everyone, and it's important in both primary care or a specialty care setting, and it can be prescribed in primary care settings. PrEP can be prescribed for any adult or adolescent who asks for it, even if they don't screen as high risk, because they may not divulge their personal information, especially at the beginning, or if it's with a practitioner who they feel knows them very, very well, and they don't want to disclose some of their behaviors. Baseline HIV testing and renal screening are essential, but also STI screening. is important at baseline and then ongoing. We monitor their HIV testing, STI screening, and their renal and lipid monitoring as well. Also counseling about ongoing STI exposure. And finally, as Ben just went over, the resources are available to assist with PrEP prescribing and patient costs, so that if you do want to incorporate this, there are so many resources available. Okay, so next slide. So we just want to thank everyone for their attention, and for all the people who went into providing this work, and for who ongoing are helping with HIV prevention. So thank you, everyone.
Wow. Thank you. And I just got myself off mute. That fabulous, easily digestible presentation, and we really appreciate it. Oh, Tom, you're back. Good. We have a few questions in the Q&A, and if people have questions, feel free to put them in there. I'm gonna let's just go one at a time. The first one is, do you document sexual history in your medical record?
I do document the history in the medical record. We have a grant for PrEP, and one of the things that the grant does require is the sexual activity we had to verify that they were eligible in order to receive PrEP, and that was from way back. So I just got into the habit of documenting the sexual history of the patient.
Okay. The next one is a comment. We would not want to use on-demand PrEP in persons infected with hepatitis B. I don't know if there's any more comment about that.
Yeah, that's a great point. Yes, because we wouldn't want them going on and off of tenofovir.
Yeah.
And so that is correct. If someone is a hepatitis B infected, if you're going to use PrEP, they would need to be on it daily, or and treating the hepatitis B as well.
Okay, and the next one, well, I have one of the questions I was going to ask is, does 211, which is on demand, work? Like, is there data that says it's, I'm just curious, this CDC says no, don't do it, but we do it, and I'm assuming it works.
So the studies have shown that yes, it works. I mean, it's not going to give you that 99%. In the studies that have where they've looked at it, the people who are actually using it were using it fairly frequently. And so in the people who were still fairly sexually active, they were still ending up taking it like 4 or 5 days out of the week. And so by the time they did the tail of it and then started again. So in that situation, it tends to work better because they do still have a lot of tenofovir in there and emtricitabine in their system. Whether in somebody who's using it pretty less frequently, whether it will work as effectively or that may be less, but it still is better than nothing. And I would still also counsel them on using condoms.
Okay, fair enough. A couple more, and Tom, you may have a question or two. Can you talk about the utility of point of care HIV and STI testing in offering PrEP?
There are other certain things you could do at point of care testing, which other labs, so you don't have to do a whole CBC. You could, we don't end up doing it in the clinic usually because we get those results back the next day. We do definitely do the point of care HIV testing in the clinic, and then also do an HIV blood test. And then we usually do order the rest of the labs. We don't do point of care for the other stuff, but you can. We just find that the labs come back the next day, so there really isn't any delay. Usually Christine can talk to the patient and get the prescription over to the pharmacy, within 24 hours or so. So that seems to work for us, pretty well.
Okay, great. I know we're short on time. So there's one more question that I'll just answer this way. Will there be any limitations in our ability to claim we provide gender affirming care, since this is critical to the success of these programs? And our position is that we provide comprehensive care for all patients, including LGBTQ plus care, and we stick by that. And so I think the answer is we take care of all comers, and we intend to continue to do that. Tom, any questions or comments?
Nope, I'm just listening. Very well done, very summarized. Hopefully we can make a lot of this information available to everybody, and appreciate everybody joining and doing all the great work you're doing.
Yeah, I just want to add thank yous. Great. And I think as a primary care doctor, I hear these talks and think I need to be doing this. I have a very small practice at this point, but I think the goal is to be sure that we're reaching out, and we will take this and well publicize it across CommonSpirit for all of our primary care physicians and advanced practice people. And I'm sure we'll be calling, and Paul is on our committee, and I just want to thank all the speakers, Marcia, terrific, and Ben and Christine. We really appreciate it.
Thank
To
you
our
very much.
listeners, thank you very much. Absolutely great. And we will cross paths soon. Thank you very much. Hope everybody has a great weekend.